Good. Well, welcome everybody. And it's actually a real honor to have Professor David Healy with us. And as someone I've wanted on our platform for a long time, actually, I've been aware of your work for many years. And as I was saying earlier, you helped me very much in a chapter for a book that I did on antidepressants in pregnancy. And those of you who are not familiar with David, he is a psychiatrist, a scientist, psychopharmacologist, and an author of many, many books, at least 25, apparently, and over 300 peer-reviewed paper, or 230 peer-reviewed articles as well. Um, and he's also called often as an expert witness, and I think that's your main area of work now, David, isn't it?
It is.
Around homicide and suicide trials involving psychotropic drugs and in bringing problems with these drugs to the attention of the American and European regulators. And he's also founder of Data-Based Medicine Limited, which started this amazing website, which if you haven't seen it, I use it a lot, and I also direct a lot of clients to it. It's called RISK, RXISK.org, which is a self-reporting drug side effects site where you can look up the drug and you can look up potential side effects. So thank you, David. It's really lovely to
Thanks,
see
John.
you.
It's good to be here.
Yeah,
Yeah.
great. All right, so we're going to be talking about SSRIs in particular and also paracetamol and the use of that in pregnancy. And then also we'll look at the use of paracetamol with children and babies, particularly because that's a very, very common drug that's used self-prescribed a lot of the time and also advised prophylactically around things like vaccinations as well. So let's start off with SSRIs and some of the issues perhaps that people might not be aware of, and particularly around how that might affect things like fetal development and things like that. Because I know that serotonin is a crucial factor, isn't it, in fetal development in terms of brain development and the gut and all kinds of things. So could you maybe start with that, David?
Yes, sure. Okay, I've been working on drugs that work in the serotonin system for longer than I like to think of. Actually, before the first SSRI, that's the first selective serotonin reuptake inhibitor, came out, I was working on the serotonin system.
Yeah.
And the first thing to say to people, I think, is look, we knew back in the 1980s there was nothing wrong with the serotonin system in people who are anxious or depressed. These drugs don't correct something. There's been a lot of marketing to say, oh, you've got low serotonin when you're depressed, or you've got a chemical imbalance. Well, no. The answer with the SSRIs is that they're working on a normal serotonin system, just like drugs like aspirin work on a normal prostaglandin system. And if
Mm,
your prostaglandin system wasn't normal, aspirin wouldn't help you. In the
mm,
same way, if your serotonin system isn't normal to begin with, an SSRI won't help you. And how they help you is they chill you out a bit. They make you less reactive. If there are things that bother you, you can sail past things a little bit more easily and not get so bothered if they're working for you. But only roughly half of the people that go on these drugs really get some help, and the
mm,
other half of us don't.
mm.
And it's a bit like LSD, which also works on the serotonin system. And roughly half the people who take LSD get a good trip, and half the people who take LSD get a bad trip. LSD opens up the doors to sensory perception.
Mm,
SSRIs close the door. They mute things. They damp things down. They make our touch less kind of sensitive. They can mute our vision, our hearing. The single commonest thing they do is they make people genitally numb within half an hour to an hour of your first pill. So that's, in a sense, the good thing that we want them to do to make you a little bit less reactive, to make your emotions, your feelings a bit more muted. But we don't want to do that too much. One of the problems can be the drugs are often used in a much higher dose than they need to be used, and people get blunted. They become emotionally numbed, And that's not a good idea. We just want to do it enough to make you less likely to react to things in an agitated way.
Mm,
So that's what these drugs do. They're not tremendously good for treating people who are very severely depressed. There can be some severe problems out of them, one of which is if you take them for too long, you can become dependent on them. And then when you try to stop them, you can also have pretty serious problems and think the drugs have saved your life because you become suicidal when you try to stop. You go back on the drug and the thing clears up and you think, gosh, I need to stay on this drug forever. My doctor said it was a bit like insulin. It's the kind of thing, once you begin it, you need to take it for the rest of your life. That's not true. The
mm,
SSRIs really are helpful for most people who they can help. They're usually helpful in the kind of problem that will clear up of its own accord anyway within 12 to 14 weeks or so. So you don't absolutely need them. They can make life a little bit more comfortable, but they're not absolutely needed for people's mental well-being.
mm,
If you're more severely depressed, then you need to be thinking about maybe going to a doctor or whoever and talking through the issues a bit more and finding out, well, what are the options for you, particularly if either you're thinking about getting pregnant or if you are pregnant.
mm.
So that's, go on.
Now, is there any actual research around the sort of psychological interventions, psychotherapy versus SSRIs in this situation, particularly with?
Well, I was involved in an SSRI and birth defect case, 15, 16 years ago, called
Yeah.
the Kilker case. And this was where the case in the United States was that Paxil, that's their paroxetine, uh, caused birth defects in this young child who was born to his mom. He had a cardiac problem.
Mm,
Now, it turned out that there was several hundred cases behind that, and
mm.
GlaxoSmithKline lost the Kilker case, and ultimately, because there were hundreds of cases, they paid out $1 billion,
Wow.
but nobody ever heard about the case. One of the things that the pharmaceutical companies are awfully good at is closing down bad news for them. So you don't get to hear that, well, there really could be issues about heart problems and all sorts of other problems. Now, the reason to mention this, to bring this up, was to respond to your question, which was when I was trying to work up the report in at the Kilker case,
Mm,
generally speaking, the medical view back then was, well, we have psychotherapies. We've got cognitive behavior therapy. We've got other therapies like this that work pretty well. So all things being equal, you should perhaps think about steering people towards these rather than towards pills. Now, this is where it gets a bit tricky. You can say to people, therapy's better than pills, but a lot of us find cognitive behavior therapy or other specific therapies don't work for us. It's a bit like the pills.
mm,
SSRIs may not work for you. Cognitive behavior therapy may not work for you either. So it isn't a simple equation. The I hate to say it, but thinking about SSRIs, here's one way to think about them. As I said to you, they don't suit all people, and there's none of the pills we use that really suit everyone. At best, they'll suit about half the people who take them. But the man who created the SSRIs was a man called Arvid Carlson.
mhm,
And one of the group of people that these drugs can be helpful for is people who've got obsessive compulsive disorder. But he was very, very clear that SSRIs won't suit all people, and not hugely surprised when a group of patients with obsessive compulsive disorder came to him at one point and said, your SSRIs don't help us. Do you know what helps us better? Smoking. So he ran a trial and he said, yes, absolutely. It turns out there's a group of people who may be helped by nicotine better than they'll be helped by an SSRI, which comes back to a point. There's a lot of things people use, from nicotine to SSRIs to whatever, that they use because they know it suits them.
mm,
And this is true of paracetamol also, which is one of the other drugs in the frame. We used to think we knew how paracetamol worked, but now if you go on the website for Johnson& Johnson, who make Tylenol,
Mm.
uh, you you find that they've stopped saying we know how it works. They
Huh.
still say it works, but we don't know how. Okay. Now, one of the interesting things about it, well, there's two or three interesting things about it. One is the clinical trials of paracetamol, a bit like the clinical trials for SSRIs. They look like the drugs don't work all that well. And the best way to interpret this, because I'm sure lots of people who take an SSRI who have a good effect are pretty sure this drug works for them. And lots
Mhm.
of people who take an SSRI and have a bad effect are pretty sure it works, although it's not helping them, it's doing the wrong thing. No
Mhm.
one thinks these things do nothing. Okay? In the same way, paracetamol, the best way to read the data is roughly half of us respond to it, can be helped by it. We get the analgesic effect. The other half of us don't. We're more likely to be aspirin or ibuprofen responders. So
Mm.
this comes back to the point that I was trying to make. One of the key things talking to anyone who may be pregnant, thinking about getting pregnant at all, is working out with them what they think they respond to.
Right.
The problem with paracetamol is, we get steered down that route when you get pregnant. You get told you can't have ibuprofen, you can't have aspirin. The analgesic you must be thinking about is paracetamol. But the half of us that don't respond to it aren't going to respond just because we get pregnant. So things can, in a sense, only go wrong. And it might be worth taking the risk if you know you respond to it, but it's not a great idea to take risks when you figure, well, this didn't help me before, but they're saying it's the only thing I can take now.
Right.
So
Right.
this is a key point. Working with the person, if they've had an SSRI antidepressant before, did it help them? If they think it didn't, well, you really shouldn't be thinking about uh, beginning it, and probably should be thinking about coming off it. It's not worth taking the risk if it's not really helping you so much just because the doctor says it works in principle,
Mm.
which may not be the same as working for you. There are always other drugs, and some of them are actually safer than the antidepressants in terms of trying to help your mood.
Mm. Um, so, I mean, what are the specific dangers with paracetamol? First, for the pregnant woman, would you say? Are there specific areas of danger, would you say?
Well, in recent years, over the course of the last 10 years or so, there's been a number of studies which say that children who are born to mothers who've been on paracetamol during pregnancy are more likely to have ADHD,
Okay.
and they're also more likely to have autistic spectrum disorder.
Uh,
Now, one of the things that has been new to me in the last year or two, looking at this, is people have been talking about the epigenomic effects
yeah.
all these drugs. And, they've looked at the effect of the drugs on the child in the womb, not prior to birth, but on the child in the womb. And there's a bunch of genes that, for instance, predispose us to autism. And they've looked at, well, how do things that we're worried about in terms of autism, how do they impact on these genes? And they've
Mhm.
looked at things like mercury, and it's
Mhm.
got a very small impact. They look at
Mhm.
things like smoking, and it's got some impact, but not huge. They look at things like older parents, older men in particular, and obesity, and these all have a bit of an impact for sure. The drug that has the greatest impact is sodium valproate, which is an anticonvulsant drug that
Yeah.
people
Yeah. Yeah.
have. And it looks like most of the anticonvulsants can have an impact on, or like they have an impact on the expression of these autism spectrum genes.
Right.
The SSRI group of drugs also have an impact, much more than obesity and nicotine and things like this. The only drug that compares to valproate is paracetamol.
Really?
So the epigenomic data looks quite strong that this drug should be causing problems. So I'm not saying don't take it. Anticonvulsants are the kinds of things that if people take them, they're on it the whole way through pregnancy.
Hmm.
If anyone's going to be using paracetamol, which by the way is an anticonvulsant, nobody knows this,
Mm.
but the trick would be to take it in the lowest possible dose for the shortest period of time, rather than be taking it chronically through a pregnancy.
Right. Right. And specifically then for infants, because as we said, that's, I mean, I have some parents who use it almost like a sweet to get a child off to sleep, um, or the slightest sign of any kind of temperature, out comes the Calpol or the Tylenol. Are there any specific things that affect infants in a negative way if it's used a lot?
Yeah. Well, this is hugely tricky, and yes, we do. I mean, we've all done that. Calpol, we've all given Calpol to our
Yeah.
kids, and we thought because it was billed as being awfully safe, much safer than aspirin and things like that, and it was a sweetish kind of liquid, and kids didn't seem to turn their nose up at it. But again, probably around half the kids may seemingly happily take it, but they may not be helped by it. Some of them will be, some of them won't be. One of the complicating factors here is, and we don't really know for sure what the story is here, but when I talked about the impact of drugs on the epigenome, that is the translation of our genes into the proteins that build us
Yeah.
while we're in the womb, what happens, fortunately, is after our genes have made the proteins that build us and were built, the genes get hidden. But that only happens till you're 2 years old. That's when they get hidden.
Ah, okay.
Up till then, your genome is somewhat unstable. So a lot of the drugs that can cause problems in the womb can continue to cause problems up to about the age of 2. So it's conceivable that giving paracetamol to children up to the age of 2 could be causing more problems than we think.
Ah, interesting. Okay. And when I was looking at, because I've studied, been following you for quite a long time, David, and I remember some of the papers that I read a long time ago, and that you've pointed out, when particularly with SSRIs, they can create, in some people, a lifelong change in sexual behavior, for example, or things like empathy, as far as I understand. Is that correct? And do you know if why that is true?
Yes, well, this comes back to the point that I was making earlier, which was that what they do is they close the sensory gate, so you're less likely to sense things. Now, the single commonest thing an SSRI does within 30 minutes of your first pill is to make you genitally numb.
Right.
Now, that can be profound. It can be marked so that, you've got no doubt, but you're feeling numb. Some people aren't particularly aware of it, but when we test them, you can still show that they're not as sensitive as they would have been normally. Now, what goes along with that is, in both males and females, what goes along with that is your orgasms mute. And
Hmm.
over time, if you're on these drugs, your libido drops.
Hmm.
Everybody assumes things are going to be normal when you come off the pills, but in actual fact, the problem can persist. It can continue for the rest of your life. Some people recover, others can remain gently numb, without orgasms, without libido for 20, 30 years or so. But there's a little bit more than that. There's, when you look at males who are on these drugs, your sperm count falls. When you look at women, there's a greater risk of miscarriage. They have an impact on anti-Mullerian hormones. So
Right. Yeah.
implantation doesn't work as well as it should, and miscarriages are more likely. So if either partner is on an SSRI, chances are of having a successful pregnancy are lower. Now, what's not clear is what the impact of these drugs are on young boys and girls before they go through puberty. If you go through puberty on these pills, we get reports into risk of people who say, well, I was put on them at the age of 7 or 8 and I went through puberty and I've never had an orgasm. I don't even know what it might be like.
Oh,
I think, I'm not sure if I'm normal. One of the other things is the animal data. When you look at animals made pregnant who are on SSRIs through the pregnancy, their offspring can be asexual later. So it
wow.
seems to make us a little bit less social and less sexual later. Again, it's probably a dose effect to some extent. In the animal work, maybe using higher doses, but that comes back to a point. If you're on these drugs while pregnant, I'm not saying instantly get off them, particularly if they are helpful, but you might want to think about titrating it down to the lowest possible dose at which you still feel comfortable. If you've been on the drugs for a while, you don't necessarily want to put yourself into withdrawal in the middle of pregnancy.
Right. Okay. And I mean, and if a woman is taking SSRIs after giving birth, is there a potential then for her to feel less emotionally empathic towards her newborn, for example? Do you think will that
Yeah,
affect sort of
but
the
that's, yeah,
attachment
sure.
and bonding?
Yeah, sure. Certainly for some people, male or female, there'll be less empathy when you're on the drugs. You're kind of a little more effectively blunted.
Yeah.
Um, and this shows up possibly in the abortion rate, which is doubled in women who are on the drugs compared with women who are not. And I've always thought some of it may be caused by you've been to a scan, you've been told about a birth defect, which may be linked to the pills you're on, but also it may also be to some extent linked to being a little bit more disinhibited, not as thinking forward as much as you would otherwise do. And it may
Right.
feel good in the moment to go ahead with this, but you may regret it later, and particularly when you come off the drugs. So there's that aspect to it that's yeah, it certainly has the potential to cause a degree of blunting that won't help the relationship after the child is born. That's
Mm.
not saying that things aren't going to work out. It's just saying that the 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 potential is there for things not to be as good as they might otherwise be.
Right. Yeah. Yeah. When I was in America recently, I was talking to a load of midwives out there, and they were saying that the percentage is around something like 20% of mums will have been on some form of antidepressant at some point during their pregnancy. And it seemed like that was possibly more likely before they knew they got pregnant. So, in other words, sometime within the first trimester, at which point, presumably, there's a lot of very important fetal development going on in that first 3 months, right?
Yes.
Can you talk a little bit about what serotonin does in fetal development and how that might be affected with this?
Yes, there's 2 or 3 points to bring out here. One is that serotonin is more primitive than estrogen or, or testosterone. We had serotonin before
Oh,
the sex hormones. So it really is pretty primitive stuff, and it affects every tissue in the body. Uh,
right,
and this is the thing that you can pick up when you see that people become generally numb, as I've said. Their skin generally is less sensitive. Now, the tissue that forms our skin is the epithelium, and that's the base tissue from which the brain and nervous system also comes.
right.
So, there's a fairly direct impact there. Um, the thalidomide um, birth defect crisis.
Mm.
Okay. 2 or 3 quick points, which may be of interest. Um, Thalidomide was kept off the US market, not because it caused birth defects. That came later. The appreciation of that came later.
Right.
It was held up by a lady called Frances Kelsey because it was causing peripheral neuropathy.
Ah.
Now, most of the anticonvulsants and most of the antidepressants also cause peripheral neuropathies.
Hmm.
Any drug that's likely to cause a peripheral neuropathy is also likely to cause birth defects. But thalidomide did one more thing. It caused all the points John has just asked me about. A greater scrutiny of the first trimester during pregnancy, because this is the point where organs begin to form, and if the drugs are having an impact, then they'll have an impact then to cause cardiac problems or spina bifida or brain defects or things like that. But the second half of pregnancy is not something that we put regulations in place to look at. As I said, companies before they bring SSRIs or other drugs on the market have to give them to animals and check for birth defects and things like this. There's a lot of regulation about what companies have to do during the first trimester.
Yeah.
Until awfully recently, and still to this day, there are no regulations for the second two trimesters.
Wow.
And companies have recently begun running, as you may know, um, randomized controlled trials during the second half of pregnancy in women with different vaccines, the RSV vaccine and other vaccines. Uh, and what we've got to realize is, since these trials began during the last 10 years or so, regulators like FDA in the United States, EMA in Europe, MHRA in the UK have no regulations about what companies should be looking for to ensure the health of the mother and the baby. They don't, they don't have to check your blood pressure and things like this routinely to see if you get the vaccine, is it causing your blood pressure to go up? Are you at risk of eclampsia? We
Hmm.
know almost by accident that if you're in a vaccine trial during pregnancy, your baby is more likely to be born preterm, and you are more likely to become eclamptic or preeclamptic. So there are things happening during the second half of pregnancy also uh, that we're really not monitoring for in the way we should, and the companies haven't been asked to monitor
Wow.
for. So you aren't going to be told that there are these things that you should be looking out for. Now, this applies to SSRIs and anticonvulsants as well,
Mm.
in that we haven't been using a pregnancy registry or things like that after women have been on these drugs to check and see how their health is and how the health of the baby is. And it's probably in the second half of pregnancy that the problems that lead to autistic spectrum disorder take place. The organs have formed, but they don't form correctly. And, they don't show up as gross birth defects afterwards, but they do show up in the behavioral um, domain afterwards.
Mhm. Interesting. I mean, again, in America, a lot of the midwives were saying they've seen so many more placental abnormalities,
Yeah.
particularly since the COVID vaccine. I don't know if you want to talk about that, David, why that might be so. Um,
Yeah. Um,
what you just said.
I don't know. That's again one of the things that on the radar for regulators that we should be getting companies if they're running trials of these vaccines during pregnancy,
Yeah.
that they should be looking at things like the placenta afterwards, as opposed to just letting a birth happen and not checking at the placenta out. That is absolutely the kind of thing that should be checked because the autism spectrum genes that valproate and paracetamol and drugs like this
Yeah.
seem to act on and activate will show up in the placenta. It's the kind of thing we can monitor for potential risks happening
Mm.
uh, that we should be monitoring and aren't. Now, one of the interesting things is a little bit of a tie back here. in the vaccine trials that happened during pregnancy, and not just the trials, but when we were told that people should be having the COVID vaccine during pregnancy,
Mm.
uh, we were also told, well, there can be vaccine reactivity, and of course, the drug recommended for that was paracetamol.
Wow.
So, you know, we may end up with the kind of situation where we think maybe the vaccine is causing a problem, when in fact it's the paracetamol that was given that may actually be causing the problem. These are things, unless we try and research it pretty systematically, we're not going to get answers for in a hurry.
Yes. I remember reading also somewhere that in Cuba, they don't use paracetamol at all with babies and children. I don't know if that's true. And
I
so,
don't know about Cuba, but all I know from what I'm reading is, as I say, if you're a person who figures you're not a paracetamol respondent like me, I
yeah,
don't seem to
I'm
respond.
not.
Of course, I'm not going to get pregnant, but there's no point taking it just because people say this is the one that you should be taking when you're pregnant. There
Yeah.
may be a point taking it in the lowest possible dose for the shortest period of time if you know that it helps you, that it really does lower temperature, not lower temperature, that it really is analgesic. One of the curious things about the analgesia it offers is it's very like the analgesia an SSRI offers. And paracetamol acts on the serotonin system also and seems to some extent blunt us a bit. It makes us less happy when we're happy, or when we think we might be happy, and less sad or in pain when we think we might be sad or in pain.
Right.
So it's not like aspirin at all, the way it works. But yeah,
Now it also depresses the breathing, is that right? It's a respiratory depressant, is that right?
well, I'm not absolutely sure about that. I don't know. But what I was going to add in when I saw you just about to ask the question was the other thing we use it for, and this is one that's interesting,
Yeah.
is we use it to lower temperature.
Yes.
But there have been controlled trials done on people who go into ICU because they're terribly seriously ill. They've got raised temperature. They might die, and some of them do die. There have been trials done comparing paracetamol with non-drug treatments. Now, what might a non-drug treatment be that can um, lower your bodily temperature? And the answer is cold sponging. It's
Cold.
anything we used to do before aspirin, before paracetamol. You'd get in a cold bath, or you'd be sponged down, or you'd sponge a child down. And the thing is, this works just as well as paracetamol lowering temperature. So, yeah.
Yeah. Yeah, I was going to ask you about alternatives. Um, so with when I mean we'll talk about alternatives in a sec, but if a mum's been on SSRIs during the pregnancy at any point, particularly say in the last trimester, and the baby's been used to this level of um, whatever is coming through the umbilical cord, etc., and then the baby's born, they presumably go through something a bit like cold turkey, do they?
They do, yes.
And because that can show up sometimes as a baby who's quite sort of distressed, I would imagine. I mean, if you come off SSRIs as an adult, you obviously have to do that in a very titrated way, don't you? But they presumably, unless they're getting it through the breast milk, will be coming off like straight away, right?
Yeah. Well, if you come off it later in life, or as an adult,
Mm.
it can be almost impossible to come off. It can be terribly, terribly difficult. Okay.
Yeah.
Some people can get off easily, but others can have a terribly difficult time and it can be close to impossible. As far as I know, babies can be jittery, they can have problems, but it does tend to clear up within a few weeks. It's not the kind of thing that goes on for ages, or it's not the kind of thing that they really need to be put on an SSRI drug,
Right.
after
Yeah.
it's titrated down, um, uh, uh, um, titrated down ever so slowly. It's it, when I was involved in this legal case, that's back around 2009.
Yeah.
The SSRI group of drugs were being used a lot less frequently than they've been used now. I mean, they've been used even more now by kind of women of childbearing years. So I guess it's happening more often. But the view back then was we recognized it's happening. We were a little bit surprised to begin with, but we've learned that yes, it can actually be managed, and you don't have to do too much. You just wait, and the thing clears up. I don't know what the story is now, whether there are more severe cases being, or more enduring cases of withdrawal problems in infants being recognized. I really can't answer that one.
No. Okay. So in terms of alternatives then, David, because sometimes, I mean, we've had a whole series on postnatal depression, which can be really, really serious. I mean, you can get psychosis, can't you? And really kind of dangerous situations sometimes are going to be horrible. And also, of course, if a mum's depressed, that's going to affect their attachment and all this. Can you go into or suggest any alternatives if a mum doesn't want to go on to SSRIs and is
Yeah. Well,
pregnant?
I think one of the things is to encourage women to look at the options themselves as opposed to being told by an expert,
Right.
so-called. One of the points that I made earliest was, you know, there are certain drugs that suit some of us but don't suit all of us.
Yeah.
And women generally, when they are thinking about getting pregnant or when they are pregnant, from my experience, do more research than any other group of people going on
True. Yeah, they
drugs.
do. Yeah.
And they know that they may have to handle risks, and they make pretty sensible kind of decisions about whether this is a risk worth taking or not. Okay.
Yeah.
So, it's not uh, a doom-laden message that I want to offer, which is if you're on an SSRI and you're finding it hard to get off, that your baby's going to have problems. That's not necessarily the case. There will be women who will be on these drugs, and if they can manage it well in the lowest possible dose, the baby is going to be fine and they're going to be fine. So it's very much a case of trusting the woman. Sure, there are risks and things like that, but women have to handle a lot of risks and usually make good calls. One of the things they won't know about, and they seem to they can get a lot of guilt out of, is that what's not particularly recognized is an SSRI drug can make you drink compulsively.
What alcohol?
The best example of this is that in some of the epidemiological work done on SSRIs taken during pregnancy,
Yeah.
one of the things that shows up 10 times more frequently in women who've been on these drugs during pregnancy than women who aren't is that they've got fetal alcohol syndrome disorder, at
Oh,
least the child has. And this is, I think, extraordinarily powerful evidence. I've been saying for a long time that SSRIs can cause some people to drink compulsively. And I think women who are pregnant are more motivated than anyone else to pay heed to the message of don't drink during pregnancy. So if they're having children born with fetal alcohol syndrome disorder more commonly than any other group, it talks to the power of an SSRI to cause something like compulsive drinking. So
wow.
this is a thing to keep an eye out on. It would be one of those things where you'd almost say, well, if you find you're pregnant and drinking and it's terribly difficult to stop, it may be a case of stopping the SSRI rather than just trying not to take alcohol.
Wow, that's interesting. Yes, because I know there are other drugs which you wouldn't think, like there's a drug for restless leg syndrome that some people take, women take, which also has caused very strange changes in behavior, sort of obsessive kind of behavior, going out shopping or having
Yeah,
multiple partners, or the weird
yeah,
things. So are there any
absolutely,
other kind
yes.
of drugs like this that
Well,
people,
yes, no, 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 sure. And they're the dopamine agonist group of drugs that were introduced for Parkinson's disease.
right?
Now, the thing is, the use for restless legs syndrome as well, you're absolutely right. But there are much safer drugs that we can use than those. The problem is you've got these drugs who we have known in terms of high court judges and lawyers who've been put on them, older men who've got Parkinson's who engage in prostitution and all sorts of things.
Yeah.
We've known that these drugs can cause disinhibited behavior. It's also now clear that it does so in younger women also. It can cause strange behavior. And if you're on the drug during pregnancy, but it's one thing to be on these drugs for Parkinson's disease. Restless leg syndrome is not something you should be taking these drugs for.
Sure.
One of the other things to throw into the mix here is just occurred to me. One of the most famous drugs that causes birth defects is a drug called bendectin, which was a combination of doxylamine, which is an antihistamine as most people see it,
Right.
and a vitamin, I think it's B6 or whatever. So what nobody knows is that doxylamine, which is used for nausea during the first trimester, okay, it's an SSRI.
Huh.
There's a lot of drugs that are SSRIs. There's antibiotics like doxycycline, which are potent SSRIs also, and can cause all the problems that the antidepressants cause. There's antihistamines available over the counter that are serotonin reuptake inhibitors. The thing about an over-the-counter SSRI, it can be a lot safer than one you get from your doctor because if it doesn't suit you, you don't continue taking it.
Right. So even I don't know if I'm allowed to say brand names, things like Piriton, for example, that's an
I'm
antihistamine.
not sure what Piriton is. Benadryl is a problem. That's a
Really?
serotonin reuptake inhibiting.
Is it? I
Yeah.
had no idea on that. Okay. And do you have any feelings or research around this new class of drugs, the mRNA type, which seem to be being used everywhere now? Do you have any
I
particular
mean,
concerns with those?
drugs are
Well,
vaccines.
vaccines, sorry.
Vaccines, yeah.
Yes, yes.
Okay, that's really tricky, and they are, as you say, being used a lot. And it's yeah, I think my big concern about it is, and my big concern about all the drugs that we take, yeah, to some extent, is the trials on them are done by the pharmaceutical companies who, and the regulators, MHRA, FDA, EMA, don't get to see the data from these trials. They get
Uh-huh.
to see a report that the company writes up about what the trials have shown. And if there's a paper trail, the role of the FDA or the EMA is to just tick a box and said, yes, we read the material that the company sent in to us. But it's a bit like Boeing who send in a report about this plane flies to the Federal Aviation Authority, right? And the FAA and the FDA and the EMA don't keep you safe when you take a plane flight. It's the pilot that keeps you
Yeah,
safe. In the
yes.
same way, a doctor is supposed to do the same thing, but a pilot has a real incentive to keep you safe. Because if you're on a plane flight from the UK to the US and you don't get there, she won't get there either. There'll be a crash and you'll both be dead. So she has an incentive to make sure the system stays safe. Doctors don't have an incentive like this. They used to have before we had evidence-based medicine in the sense of company trials being built into the standards of care. And the company trials, in some instances, being fraudulent. They claim the drug works well and there are no harms, when in fact,
Yeah.
when things end up in court, we find out, well, that this trial showed the drug didn't work and there were harms. So,
Uh-huh.
you know, doctors get trapped by the standards of care, the guidelines, the nice guidelines which say these are the drugs to use and, don't use those ones. These are based on company trials that regulators have not seen the data from. So my yeah, what all of medicine needs, but I guess particularly when women are thinking about getting pregnant or are pregnant, it needs a great relationship between the person looking after them and the woman. And key to the relationship is listening to her because she's
Right.
going to know best what works for her and things like that, rather than looking at the evidence base too much because it's seriously flawed. It's evidence that's been produced to get a drug on the market rather than evidence produced to keep us safe.
Yeah, yeah, yeah. David, have you got any ideas or research around other factors that might affect how people respond to some of these drugs, particularly kind of I'm thinking of environmental factors. I know there was a research paper a while back looking at pregnant women who lived near fields that are sprayed, with herbicides and pesticides, and there was a higher incidence, for example, with autistic kids after that. Do you have any ideas about that? What might make some of the adverse effects more potent in terms of environmental factors or the water or the food they eat and things like this?
Yeah. I don't really. All I can say, just when you introduce the theme of the food that people eat, there's an increasing amount of all these drugs in the water we drink.
Uh-huh.
And sometimes when the drugs end up in the water that we drink, they get what's called halogenated, that you get a hydrochloride ion added in or a bromine ion added in. And this can aggravate the problem that the drug can cause. Like if you've got a drug that's not hal hang on, a drug that's not halogenated,
Yeah.
uh, it may cause problems. If it gets halogenated, it's much more likely to cause problems.
Oh.
So, the drugs that are ending up in the drinking water tend to be much more halogenated than the ones we will be taking from, at the pharmacy.
Oh.
So there are issues building up in the environment for sure, but nobody's looking at these things particularly. It's one of those problems that there's PFAS and things like that. You've heard of PFAS?
No.
PFAS.
Sorry, yes, sorry, I have, yes. But
Yes.
explain. Yes,
I
yes.
forget what PFAS stands for, but PFAS
Yes,
is
I know. Yes.
usually called. And this turns out to be hugely toxic, it seems, and it's in everywhere from the Arctic ice to the Antarctic ice and everything in between. It's hard to get away from it. So things like this are building up. There's no question but that the environment is not as pristine as it used to
Right.
be. So
Yeah, I mean, I did this sort of an urban myth that, all the population of London are on a low-dosed SSRI from the drinking water.
well, no. And I mean, and you can be told something like, well, yes, it is a very low dose. Look, this is the dose you normally take, and this is the dose that we find in the water. That couldn't be harmful. It's going to be a halogenated version in the water, which
Right.
in a low dose may be doing all the things that the higher dose that we take could be doing. So,
And
yeah.
what is that process, David, of halogenation? That's the word. What is that? What does that do?
Well, it's a very simple thing. When the pharmaceutical industry many years ago, actually in the sort of birth of the drugs we use for mental illness these days, there was an antihistamine called promazine, which was very good at putting people to sleep.
Yeah.
Okay, but it didn't do much else apart from that. And one of the chemists in one of the French labs one day was playing around and said, "We'll halogenate it." Okay. And that made chlorpromazine, which was the first antipsychotic that we have.
Right.
And the thing about it was when they gave chlorpromazine to people, it did everything to every bodily system. So much so that the trade name became Largacto,
Oh my gosh.
large range of action. You know,
Really?
so
Gosh.
yeah. So this is the kind of thing that happens. These things penetrate tissues. There's a group of antibiotics, which I steer clear of. When I go in, if I have to go into hospital for
Right.
anything, I actually broke my shoulder a few years ago, so was in hospital
All
and
right.
had it fixed. And they were asking me, "Are you allergic to anything?" I said, "Yes, I'm allergic to fluoroquinolones." Now, the fluoro bit will
Yeah.
tell you this is halogenated.
Ah,
It can do things like get into your Achilles tendon and is one of the commonest causes of Achilles tendon rupture.
really?
So
Oh,
halogenation is not harmless. Sometimes it's done to make drugs stronger. The companies take a risk on it, know what they're doing, and it's deliberately aimed to make, in a sense, the drug more poisonous, to get into more systems. But all things being equal, when we dump it in the environment and we don't know what the environment's doing to it, we potentially are storing our problems.
wow. Wow. And have you because I know you're involved with a lot of different court cases, David. Have you seen any particularly interesting ones involving pregnant women and um, that you could talk about?
Well, there was the Kilker case, which was, as I said, a case that cost GSK, my understanding is over $1 billion ultimately. Not that one case, but all of the cases linked to it.
Right.
But the companies don't just close down the news about this, they also work out how to defend the other SSRIs. And,
Right.
I'm sure that all SSRIs can essentially cause the same problem, but you don't get to hear about it because the companies have worked out how to fight these cases and ensure they don't lose.
Right. And what was the
Doesn't
what was
mean
the
that they're
particular issue?
innocent, it just means what? Go on.
What was the
Yeah.
particular issue in this case, David? Can you remind me?
In the Kilke case, it was
Yes.
a young boy who had a cardiac problem.
Oh, yes.
But, you know, I looked in at the wake of that, I looked at all the evidence that was out there about SSRIs, all SSRIs causing autistic spectrum disorder. And the weight of evidence 10 years ago was actually pretty strong that they doubled the risk. So,
Okay.
yeah. So there's the whole range of problems. There's things like cleft lip, cleft palate, club foot,
Right.
cardiac problems, maybe spina bifida problems. These things are all to some extent linked to SSRIs. But again, it's a bit tricky saying all these things. It doesn't mean just because you're on one of them that your child is going to have these problems. But I think
No.
the trick is, to try and ensure if you're on one of them, it's too hard to come off it completely. Try and get the dose down because that can actually make a difference.
Right. And of course, there's a lot of interest, David, between the relationship between the gut nowadays, the microbiome, and things like depression and autism, all kinds of stuff, isn't there? Is there any mechanism that you're aware of, particularly in terms of what you've been talking about, how some of these things might affect the microbiome,
Yeah,
particularly?
of course there is. Yes. Um, yeah, no, no, sure. Um, SSRIs, I mean, people think they work in the brain. They
Hmm.
don't. Very little serotonin in you and me is in our brains. It's in our body. 95% is in our skin, our gut, our bones, our joints, our eyes, our ears, and things like that. Very little is in our brain. The SSRIs are working on the sensory receptors around our body. Now, our gut is actually not inside us. It's continuous with our skin. It's part of
Hmm.
the, I mean, if you think about it, there's a hole here, so the gut's actually continuous with our skin, and there's a hole down below. But one of the things that's interesting with all this is exercise are antihistamines, so they affect things like your skin and your gut. They're also antibiotics. I told you doxylamine, which is not doxylamine, doxycycline, which is a very
Yeah.
widely used antibiotic, is an SSRI. Well, Prozac and a few other SSRIs are antibiotic.
Wow. Okay.
So, they are absolutely for sure going to change your gut microbiome. Not just that, they're going to change your skin microbiome, which you don't hear about as much. Your skin is
Yeah.
crawling with all sorts of useful germs. It's not that they're all a problem. The problems begin when you disrupt the balance.
Yes. Exactly. Yes. Exactly. Cool. I heard recently there was a thing in Medscape. I don't know if you saw that about saffron. Did you see that about saffron?
I did, yes. That's an old story. That actually goes
Was
back
it?
a long way. Yeah.
Oh,
The SSRIs, even before sort of the issues recently about SSRIs causing problems, we knew from the 1960s, 1970s that serotonin reuptake inhibiting antidepressants gently numb you and can be used by men for premature ejaculation problems.
hmm.
That was well known way back, long before we got the SSRI group of drugs. And things like saffron were known as antidotes for problems if you were on these drugs, and to try and minimize the sexual problems that you might have while you're on them. But
Mm.
if you get what's called post-SSRI sexual dysfunction, which is the problem enduring after you've stopped the drug,
Yeah.
you don't get any help from anything like kind of saffron. We have no treatment for it. We have no cure for it, you know. So none of these things that may be otherwise aphrodisiacs seem to help
Right.
this problem uh, actually once you get it. So
Mm. I mean, people need to be more aware of it, don't they? My stepdaughter was offered an SSRI and when she was 18, and there was no talk about, well, actually, this might affect your sexual health, through your life. I mean, it was extraordinary, really,
yeah, yeah.
because she was slightly low mood.
Sure. And yes, they are being handed. I mean, people get the idea that it's just vitamin serotonin. It really can't cause too many problems. And
Mm.
you know, they're on prescription only because we figure they're more dangerous than nicotine or alcohol. We allow people to handle nicotine and alcohol.
Yeah.
We don't let them handle these drugs, themselves, partly because they're thought to be more dangerous. But in actual fact, when you go to a doctor, you almost end up with a vitamin kind of serotonin idea. You think it's harmless, and it's not. Yeah.
Devin, we got to stop in a sec. Can you just say something around fertility rates? Because I know that there's a massive concern, isn't there, that fertility rates are going down and down for both men and
Yeah.
women. Can you
Yeah.
say something around that? What do you think is causing that?
Well, this is a truly fascinating issue, and I've been writing about it and thinking about it for a while. There's all sorts of things going on, and what I'm going to mention isn't the cause of the problem because fertility rates have really dropped for almost 100 years. They dropped. I mean, they've gotten lower and lower and lower recently,
Yeah,
but they did drop down a lot to below 2.0 back in the 1930s. Then there was a bump after World War II. They went back up again and
right.
have
Yeah,
since come down. It's hard to know what's causing it. People talk about couples don't have the money to buy their own house and all
yeah,
sorts of
there's all that. Yeah,
things
yeah,
are really tricky. And there's more intense parenting, so you can't have more than one or two child because you've got to take them after school to this, that, and the other. There's all sorts of things going on.
yeah,
But for people who are concerned about the problem, if you're really trying to put it right, it looks like the incentives about a bit more money and things like that aren't making the difference. I mean, lots of countries have tried longer leave after childbirth, more supports and things like that, which don't seem to work. And I think part of the reason has to be if a significant proportion of the population, 20% of the population, are on these drugs, which kill your libido, which kill your interest to make love, which can make you less fertile, it's going to make it harder to solve the problem. The other incentives you might put in place aren't going to work as well if people just aren't making, and they aren't actually. I mean, it isn't just that they're not having babies. We know that they're not making love as much as they used to do. So
yeah,
I think these pills can seem to me to be at least playing a part in this area. And we're not having a national conversation about it. We've got the Reform Party saying we need to stop immigration. Well, do we need to stop immigration if we don't have, I mean, if the drugs are disabling people so they can't work, and if they're also meaning that we don't reproduce, then, we need immigrants to come in. But we're
mm,
not having a conversation about, well, why aren't we able to have children? Why
yeah,
is everybody so disabled at the age that they used to be having children at?
mm,
These are things that we do need conversations about, and we aren't having them.
no,
I don't have the answers other than to say we need a conversation. A lot of more
yeah,
people need to be giving their views about things.
yeah, absolutely. No, thank you so much, David. That was really, really interesting. Anything you want to say before you leave us? Anything last word?
No, no, no. Just if anyone tuning in has any feedback to offer on any of the things that have come up, I'd be keen to hear about it. So,
Oh, thank you. No, we'll let you know. And please have a look at David's website, risk.org. It's really fantastic resource. Thank you.